All right, thank you guys. Can you guys all hear me? Awesome. So my name is Fahad Ali, and I am representing, along with my team, Brown Emergency Medicine. And today we're going to talk to you about how we used anti-racist pedagogy to develop our social EM curriculum. Our only disclosure is that we were fortunate enough to receive a departmental grant to do this work. And so our goal over the next 20 minutes is we're going to do a short lecture by me, just about 5 to 6 minutes, where we're going to talk about how we developed our curriculum, what anti-racist pedagogy we used to develop our curriculum, and then we're going to go into small groups and talk about how we can develop your curriculum and hopefully learn from each other. So a little bit of background. As you all know, as emergency medicine physicians, we are witnesses to the social determinants of health that our patients experience every day. Fortunately, social EM curriculums are becoming more widespread among residencies and departments. But through all that, trainees of color and other marginalized groups have still reported a hostile learning environment, both in higher education and in residencies. And physicians from minoritized racial and ethnic groups often feel isolated and ignored in the classroom setting. And so we sought to bring in some anti-racist values and tenets when we developed our curriculum. And we knew this work was going to be important, but our department felt the same. And so here's just some of the feedback we've received from some of the sessions we've done since we rolled out our curriculum just about 2 years ago. So I'll give you a second to read some of that. All right, and so we're going to talk to you about how we implemented these anti-racist values to create that sense of inclusion that is often lacking in higher education. This is a little bit of a busy slide, and don't worry about taking pictures or taking notes. We're going to give you a QR code that has a ton of information on how we developed our curriculum and the resources we use to do it. But this is just an example of some of our objectives. In the middle, you can see the objectives and then some examples of how we accomplished them. We really wanted our residents to look at themselves and their own privilege and biases. We wanted them to look at their community and the way they interact with patients on shift and changing the way they do that. And then we wanted them to think bigger picture, like advocacy in our country and in our cities. Before we even started, we received some feedback that residents felt there was a little bit of redundancy to the topics that we covered, and sometimes we covered the same topic every year or even twice in 1 year. So we proposed a 2-year schedule. It really works out in a 4-year program where we covered one topic every other year. One thing that we do is incorporate identity and privilege and race and racism every single year because those are pretty broad topics and they're also important. For example, 1 year we talked about biased language in race and racism in the chart, and then this year we talked about race and racism in research. So here are just some of the 4 of the tenets that I'm going to go over of anti-racist pedagogy that we include in our curriculum. So we always look to bring in diverse speakers, and we want experts who are experts in their field because of their experiences. For example, we had a panel of formerly incarcerated individuals come and talk to us about their experiences when they were coming to the emergency department when they were incarcerated. And just last week, we had a resident from another program who uses a wheelchair come to talk to our group about his experiences going through med school with that, and also how we can treat folks with disabilities better in the ED. One of our non-negotiables is that we have a majority of small group discussions. There are studies out there that show that folks from minoritized populations are more likely to speak up when in a small group setting. And so this is something that we try to implement in all of our sessions. Additionally, we all have that EM short attention span, and so the less lecture time we think, the better. Here's just an example of one of our sessions. As you can see, we start with some reflection time where we usually are reading an article that was sent out before. The introduced topic is where we would have some lecturer or maybe a panel, and then we go into small groups where we'll have either cases or discussion questions that we want them to talk about. And then we always come together as a large group to discuss even further. Another aspect of anti-racist pedagogy that we try to follow is the idea of a flipped classroom. So we always have our learners involved in some way in each session and in the curriculum. We're fortunate enough to have a chief resident of health equity that is a permanent member of our curriculum committee. And so they help us learn what residents want to learn about and also how they want to learn about it. And then lastly, we don't want this work to be confined within the curriculum. You can think about how you can use it in other avenues of medical education, like Journal Club SIM, and it doesn't have to be just social emergency medicine curriculums as well. Think about ultrasound and other ways to incorporate health equity. All right, and so now we're gonna practice what we preach and go into small groups where you can either answer some of these questions or you can ask us questions. We'll be going around the room, and we just want to learn how you do your social EM curriculums and ways that we can help you improve it, or you can hopefully teach us something too.
All right, why don't we break up, just gonna take a moment to rearrange the room a bit, but, maybe four, sorry. Okay, we'll do 4 groups, so maybe we'll have kind of move our chairs and kind of make a little circle over here, kind of a circle in the back, circle over here, circle over here. So please just try and kind of work with us if the room doesn't have, and then we'll keep trying to have some opportunities. They're like, should I just back out?
I'll break the ice. And I oversee our curriculum. We're going through a cycle of like feedback, and one of the things that I'm going to get to is we've had sort of this, there are 2 things. One is sort of like bimodal interest, like you've got people who are like super interested in the curriculum, and then a section who are and help make sure we're involving everybody. And 2, and I think part of it they're kind of connected to despite trying to make the case for like relevance or practicing both relevant, it was where people who think that the topics and discussions are not clinically relevant, then I think our conference time should be relevant with the clinically relevant topics. So we're trying. We've got some ideas. You can agree, or you're getting some more ideas, but just with like this.
Has anybody else experienced that same barrier where people don't feel that it's clinically relevant?
So the barriers that we encounter is balancing fitting everything into conference time. So we have this manner laid out over lots of hours. And if you do the math, as is, it's difficult enough to fit in all of the traditional content into that time, like around meeting every couple of years cycle. We have some to make sure that we're able to keep it out and social medicine that. And now we've been doing it by allocating blocks of time and a fixed every few weeks or few conferences. There may be an opportunity for that time. We have a person that helps us, and our staff that we really helps us fit in elements of that time. But to your point, it sounds like they're distinct. It sounds like a health equity social curriculum feel separate from our content that many of us don't want everything to be one for them. So that's one of the things. That's what we've done for now. Even to the next
I think one of the leading comments works the average of our work from home, but we also are conference every 2 weeks. And so essentially incorporate social elements of health into their conversation when they're presenting a curriculum. I actually agree with the one who is brought that into our view. I think too that there was a plan initially about focusing on research and not we already have question for like and like how they just like this conversation is like what are the things that you see that impact what you know and like forward and emphasizing
And I actually got some more information of like your content. Are you introducing other things? Or do you introduce like let's say talking about social, you know, and social labels. Do you have any exception?
And so there's like one case where the desi is like social workers or needs to be at some point you're able to get that to achieve or
Last session, very
like a much less like there's one slide of your presentation. So finding a way to creatively
Yeah.
we have like our cases like again the same thing about college projects in class and things different.
If it's a
Two
lecture,
things, like maybe it's not done as a location and you're trying to send them home.
take this information.
You know, so there's always a way to kind of tailor it to incorporate challenges the other day.
When it's like,
Things are not like deletion and we're
that really helps.
I think the key thing to the IRS story so I helped kind of create our DEI committee as possible, and when we started to incorporate some of this, we got such similar feedback of this is a waste of time. This would have been better spent learning about something more relevant. And I know that our faculty member who was supporting the co-chair was very disheartened by it. But I honestly was not shocked, and I think that those are the individuals that after your program that is very interested in this are going to find these avenues to learn about it regardless of what your program does. So I think that like the key thing would be not to like, be disheartened where you're backing off against people and not incorporating all of that into there, which I don't, it doesn't sound like you're really doing at all.
sometimes
This is all how we figure out how to do it. That's why I get on this.
teach all the hard skills around
Something that's so we've been discussing in our curriculum, there's that SAEM.
putting these kind of conversations in, it's really just spurring conversation and discussion.
But it's taking a little bit and making it this that's part of your really, because the content is there, right? So it's less of a content creation and more like an integration and application. So I mean, it feels like it's really successful. Others have had success integrating that into their.
Yeah, there's thoughts that I have now that I see it where they're wanting it to be more politically relevant. So you could almost do like a comment type of thing where there is, whether it's simulated or real, is you know that there's a component of outcome that's related to the some kind of social change. Like I always tell our residents that I'm much more conservative in my workups for incarcerated patients than you know somebody that's because if we give them all these return instructions, but like, what does that really mean for them? You know, they have to give the guards attention, they have to put in the guards expect it's going to the infirmary, the infirmary has to agree that they have to be a viable transfer. Like, there's so many steps to that. I mean, no, I'm just thinking about now. Do I think it's gonna show anything? Probably not, but I want to make sure that we're doing more because there's such a disparity.
We actually talked about this, and you may have never done. I was proposition on like you said child medicine or child care. And we've actually some of the internal medicine here, so I'm not sure main idea, but it was really our goal years ago about doing like a organized structure around like disabilities centers. So you do like a narrative for the kids and a counter narrative that brings in like some of the stuff that's on the leadership are, and then you break it down into different domains. So the corporate doesn't want to share like the narrative, but yeah, but we might be able to do that.
Yeah, I mean, it's always like that idea of medication that goes with me. Are they homeless and they have their medication, and are they don't have insurance and they can't afford it? It's not just, oh, I chose.
We do an M&M format, so each of our chief residents does M&M, but our health and equity chief does like a 2-hour M&M with 4 cases that are all like devastated or is that like something that's based with something like that. And that's been very well received by our faculty.
Really interesting distinction. I just started, actually, the young chair. I started advocating this year. I'm kind of hearing these discussions, and I think I've been that's why, and one of the challenges is like, I think, I would say like 95% of our patients like are very like are basic like basic barriers. And so kind of pretty much every application whereas and have and we are and I do plan later like integrated and out in rural areas, you know, we think in advocacy, like, I mean, I have to talk to you more about the formal curriculum, but one of the barriers I see is just practicing and then be like, oh, be aware of it. I can just feel myself afterwards and be like, I'm aware of it, whatever I do about it. And like, there's a lot of these things where it's like, we reach out to people, and really, there's not more. I think they're just, I mean, yeah, how do we get these tools and also be like, we can take this into account without being more analysis or dealing with processing, no control over, like, can't really help, like, there's only so much.
I completely, you want to give them something tangible that they can actually act on, and we had that feedback repeatedly in our first year. So then usually we're recruiting experts whenever that field is, like whether it's incarcerated populations, we have like attendees that work in our group that also work at the prison. And that was like one of our objectives for them when they come in is like to come up with tangible takeaway things that we can do. And one of them is like, they say like, hey, recommend a non-emergent radical partial ultrasound that you do it in the ED because they're never gonna get that appointment probably for about a year. So sometimes they're not super satisfying, like things you can do, something as simple as that, again, just a little bit to be empowered by. But it's really like whoever the expert is that you're using as a content expert, so you ask them, like, what is something that we can actually do, make sure that comes across to your resident.
And also, like,
And they want us to really walk through the thing with so many elements. It's very much not right on.
but when you do this, you recognize there's a million things you can talk about. Let's talk about this one. Let's make it a single point. Let's make the fight. Because it's single. Yeah. And then you got this focus over time. It's a design. And sometimes you build enough of those and that answer can be understanding your because that's super time. Each one gives so many different versions of
One of the things that we did, and I think was really eye-opening, is everybody was like, we call social work, and they bring them resources. We're like, what's in that resource? So we had the residents sit there with the resource list of all the shelters and call the numbers. And most of them are not working numbers. You can't get anybody like after 4 o'clock. Like it's really difficult. We're like, this is what you're confidently like hand to patient saying, call all these resources. So it was like raising that awareness to be like, how do we then change that? And that opens up another discussion. So, or how do you get from the emergency department to your home to like a doctor's appointment, like all on public transportation from Providence, which doesn't have a good public transportation. So like just raising that awareness,